Good afternoon. Welcome to today's Medical Center Hour, a program called Being Open with Patients and Families about Medical Errors. I'm Marcia Day Childress from the Center for Biomedical Ethics and Humanities, and we're pleased to bring you these weekly programs through the semester. Our Medical Center Hour today is the School of Medicine's Richardson Memorial Lecture, a lecture which occurs annually to remind and encourage our health professional students, house staff, and seasoned practitioners to be reflective about their work and about the errors that regrettably do occur, and especially to attend with care and compassion to the persons who are their patients. Made possible by the family of the late Jessie Stewart Richardson, this lecture had its origins in Mrs. Richardson's untimely death, a result of tragic adverse incidents in her hospital care. Remembering Mrs. Richardson's long career as a school teacher, her family chose to invest funds from her estate in health professional education and patient safety. They are thus helping the School of Medicine and the Medical Center to foster clinicians' interest in patients as persons, to underscore health professionals' commitments to care, to giving care that has the patient at its heart, to help clinicians appreciate that patients have something to teach their doctors and nurses, and to explore without fear the medical mistakes that do happen and how we individually and institutionally might better respond to and remedy harmful errors in practice. Over the last 10 years, the Richardson Lectures have brought many distinguished speakers to Charlottesville, among them physicians, physician ethicists, a medical sociologist, physician writers, a poet, even a patient's spouse. These annual lectures have also enabled us to chart the quite remarkable evolution of public awareness, professional responsiveness, and healthcare policymaking with regard to medical error that has occurred over the last decade. We began these programs at a time when medical error was pretty much taboo, especially as a subject of conversation between doctors and patients and their families. Around this same time, in 1999, the Institute of Medicine issued its landmark national report on mistakes, To Err is Human, Building a Safer Healthcare System. In the years since then, medical error and patient safety have become subjects of much open discussion in the public square, by regulatory bodies, by healthcare institutions, by physicians individually and in groups. These have also become the subjects of intense study, education, and conscientious action across the spectrum of healthcare, with the result that disclosure of adverse events to patients and families is now expected. Yet all this time, medical care, especially within tertiary care hospitals, has grown ever more sophisticated, complex, and complicated. No care comes without risk. While we still have distance to go before disclosure of error is always handled well and patient safety always comes first, we're in a very different place today at UVA and nationally than we were 10 years ago. Indeed, for example, what was virtually unspeakable then is now paid attention to in a very public way. This week, the 7th through the 13th of March, we observe National Patient Safety Awareness Week. I'd like to welcome today to our program Dr. Don Richardson, Mrs. Richardson's son, and a local physician who is also an alum of the UVA School of Medicine. We're delighted to welcome to UVA also our speaker for today, Dr. Albert Wu, an international leader in patient safety and communication about medical error. Dr. Wu is Professor of Health Policy and Management and Professor of Medicine at Johns Hopkins University's Bloomberg School of Public Health. He's been working and writing on disclosure of medical error from the perspectives of physician education about communication and institutional policymaking throughout his career. You'll find a brief bio sketch of Dr. Wu and a nice list of resources in your handout. His talk today will address how clinicians and the healthcare organizations in which they work might best prepare for and handle communication with patients and families about adverse events. I'd like to thank the Patient Safety and Risk Management Program here at UVA Health System for their partnership in helping us organize this program and bring Dr. Wu here. And I think of this as a sort of public-private partnership because we work as a public institution with a very committed private citizen and worthy alum of UVA, Dr. Richardson. So it's a nice kind of alliance to celebrate. So thank you. Albert?
Well, Marcia, thank you so much. And I wanted to thank UVA and particularly Dr. Richardson for the privileges coming here and participating in your medical center hour. It is an opportunity which I've been waiting for perhaps 10 years, approximately. And I feel somehow, I think I'm going to talk a little bit about closing the loop with regard to handling medical errors. And I somehow feel that, there's good karma associated with this year's event. I wanted to talk about being open with patients and families, which I think that we should be doing even when we're not talking about medical errors. And I think that it's true that our thinking has evolved quite a bit over the last 10 years, so perhaps it's just as well that I'm only now getting to you. I really want to start with a little bit of a video clip which will express much better than I really can the importance of this problem.
My name is Sorrel King. My daughter Josie died in the year 2001 from medical errors at Johns Hopkins, one of the best hospitals in the country. She was brought in with first and second degree burns, and 2 days before she was to come home, she died of severe dehydration and misused narcotics. These were preventable mistakes, and this did not need to happen.
Unfortunately, mistakes are inevitable. All practicing physicians make mistakes, and any physician who sees many patients will eventually be involved in an incident where patients may be harmed instead of helped by medical care. Patients and their families can be devastated by a mistake in their care. Healthcare workers, including physicians, also have powerful emotional reactions to learning that they may have made a mistake that harmed a patient. However, there is broad consensus among medical professional organizations, ethicists, and lawyers that physicians and healthcare organizations are obligated to disclose the occurrence of a harmful mistake to the patient and/or family member. Full disclosure is not only the right thing to do, it also enables all parties concerned to cope better and more constructively with the error. Ultimately, it helps institutions to learn from their errors.
At night, we took her off life support, and she died in our arms on a snowy night in one of the best hospitals in the world. About a week and a half after Josie died, George Dover, the head of the Children's Center, came to our house and sat down with my husband and I, and he basically said, this happened at my hospital, this shouldn't have happened. I take full responsibility, and I'll get to the bottom of it, and that there would be a committee assigned to investigate what happened, and that in a few months they would come back to us with the results. He also said that his phone would be available for me and for Tony, that he would talk to us every Friday at 1 o'clock, for however long we wanted. So every Friday at 1 o'clock I would call him. Most of the time I would call him and scream at him, and threaten to call the Baltimore Sun, and threaten to call the New York Times, and threaten to go to Good Morning America. And he would sit and he would listen. Hopkins did the right thing. They came forward. They told us exactly what went wrong. They apologized, and they said they would fix the problem.
So, I think I appear next in the video, but you get me live instead. I think it should be very obvious why I wanted to start with this clip and the event that Sorrel described changed our institution. And once that happened, there's really no going back, I'm happy to say. We've all been changed, and interestingly, our malpractice insurer funded our making of this educational video. You also saw my colleague Peter Pronovost up in the beginning. And this is one of the resources that we use to try to help people understand how important it is and how to disclose an adverse event to a patient, how to handle these events. But it's also important to try to engage people, to make them understand just how important this is. I thought it'd be nice to start with this quote from this gentleman who's well known to you. Reason and free inquiry are the only effectual agents against error. And we really need to know about things, aside from doing right by patients and families, we need to know about things in order to be able to improve ourselves. If you're interested, Josie's story is now described in basically the way that a mother would write about her child. It's a terrific book, and this is not medicalese, this is not someone who's been professionalized. I think it's really very instructive. I actually wanted to mention how I got into this whole area, and I didn't realize this until, honestly, just a few years ago, but then it sort of came back to me. This is a case from early in my career. In fact, it was when I was a fourth-year medical student, a sub-intern at a prominent Upper East Side New York hospital located on the East River. And I guess it's in my bio. And it was my first day as a sub-intern on the medical wards. Are any of you medical students? My first day, and I was very excited. It was one of the private services, and I got oriented to the unit by the head nurse, who was a very wise and experienced woman. She was an older woman, probably 30. And my first patient arrived, and it was a 65-year-old woman. She'd been in the CCU. She came out. She'd had a little trouble with heart failure after her MI, but I was ready to give it my all, to take a good, thorough history. Wasn't going to take more than, an hour and a half to do that. And then maybe we'd have lunch because we would be tired. And then do a physical, wouldn't take more than about an hour. But she was actually not with the program. She was actually really quite ill, as it turned out. She had rapidly progressing shortness of breath. I was surprised that the cardiac team appeared suddenly. Started taking the headboard off the bed, giving her oxygen via an ambu bag. And then at some point, and I later realized that this was a communication issue, the cardiology fellow who was running the code called for, made an order to the air, for 2 milligrams of morphine IV push to help her with her pulmonary edema, an appropriate order. I had never been in a code. I was kind of excited. And I was, for better or worse, was standing next to an IV port. And maybe I thought she said push this, or someone pushed this, and I took it and administered the syringe, 10 milligrams of morphine, IV, push. So has any of you ever have any of you ever received 10 milligrams of morphine IV push? And you've given it a similar dose to a patient? Well, she reacted in a predictable way. Her breathing slowed to about 2 breaths per minute, and that was just before she was intubated. Fortunately, there was someone at the head of the bed who could intubate, and she was intubated and whisked away. And went back to the CCU, and I was sort of left standing there in the room. And for those of you who have been in a code lately or ever, the room looks really bizarre, actually, after a code. The bed is missing. There's stuff everywhere. The crash cart's in a corner, but things are just pulled out of it and thrown around. And I had a very significant sense that something had gone wrong. And it literally one of those sort of chilling feelings. And I had a feeling that I had been a participant in that thing. And the head nurse was the only person in the room, and she said something to the effect of, "That was a lot of morphine." And I sort of didn't say that. She said, "Well, come on, come back to the nursing station and let's talk." And so I went with her, and she told me about a case where, when she was a nursing student, she'd given an overdose of a medication to a patient who'd been harmed by it. And she said, "I just about quit." But then she got some advice that, these things happen to everyone who practices. And you've got to learn from it and go on. She said, "Have you learned anything?" And I said, "Oh, yeah, I've learned quite a lot, I think." And she said, "Well, okay, and I don't think anyone else really needs to hear about this." And I was relieved initially, but I also thought, is it true that no one really needs to know about this? And I thought this when I was visiting the patient every day, twice a day in the CCU. And she went home. I was very happy about that. But no, the attending was never told, as far as I can tell. The patient was certainly never told. And years later, when I was casting around for a research study to do, I thought about actually not this case, but another case that I'd been less involved in, and sort of posed as a question as a fellow. Well, what happens when people make mistakes, and do house officers, medical students and house officers, learn from their mistakes so they change their practice? One of the things we found, we got people to describe significant mistakes, and of these house officers, almost half responded, and all of them reported serious errors. And interestingly, only half told their attending. These were incidents, 30% of the patients had died in these cases. Whether or not it was because of the incident, who knows. And only a quarter had told the patients or family. And when I've presented these results, some people thought that was terrible that these patients weren't told. And other people said, a quarter of the patients were told. It's pretty good. It may be more than you'd expect. So a few years later, I found myself helping to write a policy for our hospital on disclosing errors. And we pretty rapidly came to the position that it is the right of a patient to receive information about medical errors that happen in their care. Also importantly, the institution would handle it in such a way that promptly reporting something that happened would not result in punishment. Because even in the rare case when that was appropriate, that trickle of reports would soon disappear. And it was heartening that this was put together. We put it together almost over a year, presented to our medical board, to the hospital board, and they approved it on the spot. They said, "This is part of our core mission. This is what we should be doing. This is our policy." And so ever since that, it has been. And when the case of Sorrel and Josie King occurred, we actually had a policy in place, and I think we handled things after they happened about as well as one might hope for. That said, a lot of people still, a number of people are not aware that we have a policy at all, even though patients are told when they are admitted to the hospital, they get to see a very brief video clip which says, things go wrong, sometimes things go wrong. If you see something, let us know. It's your right to know when things go wrong, and we'll tell you. But a few years later, there was an incident where a surgical physician made an error with a patient. Wasn't quite sure what to do, was flustered. Is anyone a surgeon? Anyone? So anyway, the surgeon didn't know what to do, so he did something which he did know how to do, which was transfer the patient to medicine. And that might have been a smart thing to do, and maybe good for the patient, but the resident who received the patient was not happy. And I won't replicate the conversation, but confronted him and said, excuse me, can you please tell me why you didn't tell anyone? In not so many words. And he said, he was very contrite actually. He said, I just didn't know what to say. I froze, I didn't know what to say. And it's one of those facts of life that you're more likely to do things that you feel comfortable doing. And this is something that makes people acutely uncomfortable, even thinking about doing it. There's a lot of barriers to disclosing, just plain old shame, fear of the consequences, both in terms of discipline and maybe lawsuits, and ignorance. And one thing which is actually really distressing is thinking about the fact that you might tell someone something and they might get upset. Maybe we're a little further down south than where I trained, but getting someone upset in the East, it's like worse than death. We thought that ignorance in particular was something that could be confronted, though all of these things really need to be taken into account. It's everything that I'm going to say, that I'm going to summarize now are just things that we basically should, we learned sort of when we were in kindergarten, on the playground. One of them is that people expect an apology. If you do something wrong, they expect you to apologize, and you know that you should apologize. I didn't drive here today, but something like this actually happened to me not that long ago. I pulled into a parking space. I was a little late for a meeting. Dragged open the car door. Ding. Bumped the car next to me. And what's the first thing that you do when you hit someone else's car? You look around to see if anyone is looking. And then if there's no one there, what do? You move the car. You pull out of the parking space and park in another parking space. No, I didn't do that, though. I wrote a long note with my name, my phone number, my cell phone number, my insurance number, my license number, my social security number. And I made 2 copies. I put one under the windscreen, under the windshield wiper, and stuck one through the window so that it would fall on the driver's side seat, so they would make sure that they knew that I felt bad. I'm sorry, I did this. I'm good for it. Call me. Not everyone. I don't know if any of you ever got in a little car fender bender, but I'm not sure everyone does that all the time. And this is not talking about. We're not talking about harming patients. We're talking about parking the car. It's not a natural inclination. There's a conflict. You know you should apologize, but it's really hard to do. Interestingly, it's so hard to do that when really bad things happen, there is often more than one victim. And caregivers, doctors, nurses, and others, can be really traumatized by it when bad things happen. I think this is also worth taking into consideration, and we've really ignored this largely. If anything, our institution has gotten better at disclosing to patients, but almost at the expense of ignoring the needs of physicians and nurses who might really be suffering from PTSD, honestly, after some of these really upsetting incidents. So this is something to keep further into account. I actually wound up writing about this a little bit when I was about 10 years ago. And I think this is something which is now, just 10 years later, coming into, onto people's radar screens. This is, I know we have some psychiatrists in the room. This is that what's the kid's name? Timmy. So this is Timmy, and he's, it looks like he's drowning. He's saying, Lassie, Lassie, get help. So there's Lassie getting help. And, this is something that we actually have neglected. I think we do need to think about patients first, but for our healthcare workers to keep showing up every day. We had a terrible incident in the emergency room a couple of years ago in which a child came in and could not be intubated and could not be trached after he'd been paralyzed so he could be intubated. And it caused just more distress than you could, that you can imagine. And people had trouble getting back to work. They said, gosh, it's like going back to a war zone. And so, again, I think we do need to think about this. Patients, of course, feel terrible. They may be frightened by what happened to them, but they also feel a lot of other emotions, including anger. They may feel isolated. They feel guilty, oddly enough, and they may feel like somehow their trust has been betrayed. We need to think about these things when we're talking to patients. Patients have very important needs when things go wrong, and I think you can think of them as clinical needs, which we're pretty good at taking care of, but they have informational needs and emotional needs, and we have historically neglected those. We think we know what they need to know, but they want to know what happened. They really expect us to apologize, and they interestingly want to know that something is being done to prevent this from happening to someone else. And this seems overly altruistic in a way, but it may simply be that it seems so wrong that things can go wrong in care. People feel like people don't understand. They feel that somehow something is cosmically wrong, and they need to be reassured that steps will be taken so that other people can suspend enough disbelief to actually entrust themselves into people's care. I really think there's a little bit of a golden hour for disclosing. When something goes wrong, immediately after it happened, you can tell them about it. And if you do that, you are telling them about something that happened in their care or with their health, just the way you tell them about everything, hopefully, that's happening to them. When you delay, when you see them a number of times and don't tell them that piece of information, if you ever do, when you eventually do disclose, they may think back and say, gosh, all of those times we met, he knew about that and he didn't tell me. A error is a real threat to doctor-patient relationship. It really threatens the trust that you have, and not disclosing or delaying really further undermines that. And I think this is something that we need to take into account both in our practice and in policy, to tell someone, we'll let you, gosh, I'm sorry that you're doing so badly, we'll let you know just as soon as the investigation is completed. That might be 2 months. Is not the right thing. You need to tell people what you know as soon as you know it, and then reassure them, tell you about it later. We have some ground rules, but these things shouldn't be scripted. In general, the patient's doctor should be the default discloser. Things should happen in as much real time as possible. You really need to assure privacy. These are very stressful discussions for everyone. And you should tell them just as much as you know. It's worth thinking about this as just part of the dialogue that's been going on ever since you met the patient. And if it seems more like that, it seems more normal. It seems less deviant that you're telling them about something. And quite honestly, many of our expectations on both the patient and the doctor's side are unrealistic, and bad things happen. Most of us haven't been trained up to these. It's possible that some students are now being trained about breaking bad news, or certainly about rather disclosing adverse events, and some about breaking bad news. But we have more experience with breaking bad news, and this is just an example, a special case of breaking bad news. We can do that. Again, I think that the last thing we want to do is prescribe a script, but it's worth saying pretty early on that something bad has happened. And that's because people often, once they get really bad news, shut down a little bit and don't receive a lot of the other messages that happen. So if you start with the good news, you may not get your message across. Very important to use non-technical language. You need to explain what happened, what's been done, what will be done. It's crucially important to express regret, your own regret, and it's certain that you'll feel badly about it, and to apologize, to ask questions, find out if there are other concerns, and then plan the next step. This is just the first in what should be several conversations. Things not to say, and sad to say, these are things that I hear over and over. Well, maybe what happened was really for the best. It's God's will. Well, at least you have another family member, child. This has never happened to me before, and that may be true, but this is actually not about you, it's actually about the patient. It's really important to understand that saying I'm sorry is not the same as saying I am guilty, and I think that there's a real confusion in people's minds about this. An apology can and should be appropriate to the situation. If something happened in the system, something got lost, you can say, I'm really sorry that this happened, and you can explain to the best of your knowledge that there are a number of steps and checks and balances, and for some reason, this fell through the cracks. I'm really sorry that this happened. However, if you did something wrong, I prescribed an antibiotic for a patient a few months ago. It said allergic on the chart. The woman came back and said, I feel much better, but I've had this funny rash. And I said, oh my God, I shouldn't have prescribed, you're allergic to the antibiotic, I shouldn't have prescribed it to you. I'm so sorry that I did that, and it was very obvious that it was my mistake, and the appropriate apology was to say, I am sorry that I did this. And she actually let me off the hook. She said, oh, doctor, I'm allergic to everything. This is a skill that can be taught, and this is a case of more or less a case that happened at our institution. Mr. Smith, who's a healthy 71-year-old gentleman, has chemotherapy after successful surgery for relatively early colon cancer. He's hospitalized 2 days later with multi-organ system failure. Is in the ICU, is looking very, very, very bad. The physician looks back at the orders and realizes that he made a miscalculation. He actually made a decimal point error in the calculation, and the patient got 10 times too much chemo. And he is now going to disclose this adverse event to the patient's daughter. Now you wonder why I said the physician is he and the son is she, and that's because we have two very gracious volunteers to have this discussion. Can I call on you now? So, Posey, you are the patient, or you're the patient's daughter.
Okay.
You actually have never met Dr. Moore.
Okay.
And you're a little bit, you're sort of an emotional person. Some say you've been described as, some have described you as histrionic. You certainly react. Dr. Moore?
Yes, sir.
You're an internist. You still write your own chemo orders, which in retrospect may or may not be the best thing. But you have not met the patient's daughter, and you're going to introduce yourself and explain to her what happened and have a good disclosure discussion with her. Now, it's possible that things may not go so well. And it's good that you're so calm. And
Not inside.
the audience can help. And if you sense that things are spiraling desperately out of control in the discussion, we'll call time out, and we'll stop the action, and we can talk for a minute about what perhaps could be done better. And then we'll pick up again. And that'll give everyone some breathing space. And is everyone clear? All right, you're clear on are you ready to jump in to intervene if need be? Okay, great.
Hi, you're Mr. Smith's daughter. I'm Dr. Moore. I'm the one
Dr.
that's...
Moore, I'm so glad to meet you.
Yes, ma'am.
I just really need to talk to somebody. I really don't understand.
Well, I'm here to
what's
listen,
happening,
too.
so I'm really glad you're here. I'm just so confused about all of this. And it's so upsetting.
Yeah, he's not doing well right now.
No.
We got our medical team there.
Right.
Unfortunately, I had a part to play in this.
A
Because
part to play in this?
in him not doing well right
Uh-huh.
now. I'm not exactly sure how it happened, but I got the decimal point in the wrong place.
I'm
and
sorry, you did what?
I got the decimal point in the wrong place. The amount of chemotherapy that was given to him was way more than it should have been. And
So you're telling me that he got more than he was supposed to get?
absolutely, yeah.
And that this was something that you did to
I
my
did it.
father?
I did it, yeah. Yeah, I mean, I very much feel terrible about it, and
I should expect that you would feel terrible
Yes,
about
ma'am.
this. I mean, my father's doing horribly. I mean,
You're right.
horribly well.
Absolutely. Absolutely. It's a terrible thing. It's,
I don't really know what to say. I mean, I don't really know what to say. I mean, this is just terrible.
it is. We're doing, of course, now everything we possibly can to turn this around. And I realize in a way there's nothing that I can say that can turn this around.
No, there really isn't anything that you can say right now. I mean, I mean, you know, are you going to lose your license over this? I mean, this
I don't know.
seems like
I don't know.
something you should lose your license
I don't know.
over.
I mean, that's all stuff that's going to have to be dealt
I'm
with.
going to have to, I'm going to have to make some phone calls because this is really not so bad.
Well, I understand that. I understand that. I think right now the primary concern
I got some indications from someone who has something to do with the institution that maybe a timeout would be appropriate. Anyone else feel like what's going well about this discussion so far? He's sitting down.
That's a plus.
That's a plus. What else? What other things are going well?
He's not over talking.
He's being honest.
He's not over talking.
He's letting her talk some, yeah, and he's certainly being he's not being overly garrulous about all of this.
He's being non-defensive.
He's not being defensive. He's he's agreeing. Are there things that you think? Are there any opportunities for improvement?
He hasn't said I'm sorry.
He hasn't said I'm sorry. That sounds like would be called for. Could even have been said, at this point already. Other things that that could be going better.
Start a plan, what he's going to do.
Plan. So he hasn't gotten to a plan yet. What about that decimal point error? How it happened. How come my dad's getting decimal points? What's up with those decimal points? He got a decimal point he wasn't supposed to get? It was a little confusing. I mean, I followed it, but I had to think for a second.
Yes.
Other things? So how is what's empathy? My wife would like me to be able to give her an answer to that question.
Well, I know he seems like he's saying pretty much the right things, but I don't feel like he's being very sincere.
You don't feel like he's being very sincere.
Yeah,
Is he being a little cool, maybe?
Or it's coming routinely. It feels almost like, well, yeah, I've done this before.
It'll happen again.
Yeah.
I still have my license. Go ahead, try to sue me. It hasn't worked before. Is she, yeah.
He's saying a lot of I stuff. I feel terrible. I can't say anything that's going to help this, but he's not really addressing how she feels.
Right, so she's expressing quite a bit actually, but that's good. That was the prescription. But how's he reacting to her reactions? So what's empathy? What's empathic behavior? What are you supposed to do?
Reflect back.
So you're supposed to, yeah, you folks know more about this than I do, but at least that's what my wife says. But so you're supposed to acknowledge what the person is expressing or feeling. So if it's anger, you can say, I can see that you must be really angry. I can see that you're really angry, and then you're supposed to, really validate that. I can understand how you would be angry. I would probably be really angry too, and then you've got to say something that's difficult, which is, and I realize you're angry at me or with me for what happened, what I did. It's hard to get the words out, but you've got to make the connection between their emotion and something about you, if that's what we're talking about. So other things that you want to see happen, or should we just let them continue? Yes?
I think he looks too relaxed. He's had his leg crossed the entire time. He's not leaning toward the patient as if I'm really interested in what you've got to say. He's back and relaxed, like going to the, just to the movies or whatever. To be engaged, you've got to be leaning toward the patient and really.
So the funny thing is that I think that I didn't quite sort of verbalize that. You said it better than I would have, but I was aware that he seemed a little bit casual about all of this, and maybe you do want to put people at their ease, but body language is important as well as the words you say. People aren't even hearing a lot of the words you say at some point. That sort of that rushing in your ears. And posture, it's good that he's sitting. It's very important not to, let me tell you about what happened to your father, because, she's at the maximum of her powerlessness right now. And what you need to do is try to make her feel, more comfortable. And so getting yourself to the level of patient is important. Making eye contact is good, which you actually have done. Acting interested, is almost as good as being interested, but if you are really empathize, if you are really feeling what the patient is feeling, then you don't need to act. You will lean forward. You'll look at the patient. You'll put yourself on their level. You will, you'll be really in the discussion, and that's important. The patient needs to understand that you, in fact, really do care about them, which I'm sure that you care a lot about what happened, and I'm sure that you care about them too. But conveying that is comforting. Yes?
Another thing, to get bad news, you've got to give them some hints before you tell it. And so Don just kind of went in, well, I gave him a decimal point too much. That's how he started, instead of saying, well, your dad came in two days ago for chemotherapy, and we gave him an amount, and he got sick, and so forth. And by the time you tell her, I made a mistake, she already has guessed that you've done something wrong.
Right. It is difficult to get in and out of these conversations, and the old cliche, are you sitting down, and then the person bursts into tears. is just that, a cliche, but sort of basically letting people know that you might say, I have some bad news for you, or something like that, or I have something serious to talk about, so that you have people's attention and you can get into the discussion. It's also sometimes worth trying to figure out how much they know. What have they told you, or what do you understand about what's happened so far, and then pick up from there. It really is very important to follow the patient's cues. In the interest of time, I think we should give these guys a hand and let them off the hook. This is really very, very difficult, and I'm not sure that any of you sitting in that seat, especially that seat, would do that much better. Even when you know how to do this and have done it before, it's funny, the words are difficult. It's hard to get the words out. It's hard not to use technical terms. It's hard not to qualify things. A little too much chemo. It may have done this or that. It's just really, it's really hard. Here's another version of that discussion.
Good morning, Mr. Smith. I'm Dr. Greene, your father's physician. As you know, your father is not doing well, and I'm afraid that I have even more bad news for you. In reviewing the notes regarding the chemotherapy, it appears as though I miscalculated the dose to be given to your father. This was not noticed by anyone else, and your father was given a dose that was actually 10 times the amount that he should have received. This is probably why your father is so sick now. Mr. Smith, I am deeply sorry for the harm the overdose may have caused your father, and I also regret the pain that this condition is causing you and your family. Please be assured that we are doing everything possible to take care of your father at this time. He's on a ventilator to assist his breathing. He's receiving kidney dialysis. He's receiving medication to maintain his blood pressure, and he's being monitored around the clock.
Why didn't anyone notice that he was getting such a high dose of chemo? 10 times is awful high, isn't it?
Yes, 10 times the dose that should have been administered is a very high dose. I can assure you that we are doing everything possible to determine how he could have gotten this kind of overdose. We are conducting a thorough investigation involving pharmacy, nursing, and myself. We hope to learn how to prevent this sort of overdose from happening in the future. Are there any questions, sir, that you may have of me at this time?
What does this mean for my dad's health?
At this point, we are simply doing everything we can to keep your father as comfortable as possible. I would like to meet with you tomorrow at a time that's convenient for you to share any additional information that I may have learned.
Okay.
So, this wasn't a perfect discussion. There's no perfect discussion, but she did some things that perhaps are good to do. I think that she did a pretty skillful job of sort of getting into the discussion. Things aren't going well, and I've actually got more bad news. I think she apologized appropriately. She just is a fairly sympathetic person and seemed to be, sort of attentive to what the patient was saying, though he wasn't very reactive. And she did explain what was happening next and a little bit of a plan. And we've been using this in a series of other videos in our training courses and materials to help people do this better. And this is definitely something that can be taught. Some people are naturally better at this. But you can definitely get better and more comfortable at having conversations of this kind and almost any kind. There's recently been, since actually for 5 years now, but it's beginning to be much more clear that not only might this be a good thing for patients and the right thing to do, but in fact it may be good for medical centers, and it may even be help to reduce malpractice claims. This is a case where a patient said he made an effort to seek me out and say I was sorry. Moved by the doctor's contrition, she dropped plans to sue. And this sort of thing, we hear this a lot. There is some data, though limited, there's a little debate about this. Is disclosure a good defense strategy? And I'm not an expert on this, and I'm not really necessarily advocating strategy. Some have argued theoretically that if you tell people about things that went wrong, some of them may sue you, and that's true, but no, I don't think any of us are now in this day saying that we should actively cover up our errors. But there's evidence from the Lexington VA hospital in Kentucky, University of Michigan, our own place, among others, that that the institution may do better as well. Part of the reason our malpractice insurer thought that people should simply be trained about the importance of disclosure and how to do it well as opposed to do it badly. Actually, I won't show this very much, but the Lexington VA in 1997 started a policy of full disclosure of adverse events to patients, even if the patient wasn't aware of it. And they would often offer a rapid settlement if there was something that they thought that they had done wrong. And what these plots show is that the number of settlements that they made over the next several years was relatively high compared to all other VAs on the East Coast, but their total payout was in the bottom quartile. So what happened was they had lots of settlements for people who were injured. They settled rapidly, sometimes within a month, as opposed to several years for a malpractice case, and people got compensated probably appropriately. At the University of Michigan, they modeled their policy after the Lexington VA, and their claims are down, their costs for litigation, defending litigation are down, time to completion has gone down quite a lot, and they, perhaps most telling, they've reduced their indemnity reserves, which they hold in case they need to pay out, from $72 to $20 million. We did a study recently, which was published this summer, on patients' perceptions of disclosure discussions. And what we actually did was had people from East Baltimore mostly watch the video like you saw and then say, how did the doctor do? Did you like her? Did she do a good job? Did you trust her? Would you want to have her for your doctor? And also, would you feel like suing the doctor? I think the most interesting thing that happened was that we also asked, did the doctor apologize? And we had scripted it in. In some of these videos, the doctor apologizes. In other cases, they don't at all. But what I thought was an apology was not apparently always an apology to the people seeing the videos. And sometimes they said, no, the doctor didn't apologize. When they saw and heard an apology, they rated the doctor much more highly, trusted them much more, and were even likely to sue a little bit less. So I think the bottom line is, if you're going to apologize, really do it. Make sure the person hears you. It's important to take some responsibility as opposed to pass the buck infinitely, but also it's important not to, no jousting. You shouldn't be naming or blaming or criticizing other people in the system. After all, in general, no one has more role than anyone else in the way we've set things up, which is inherently hazardous. Very important to avoid a few things, to manage yourself. One, a key thing is that it's important never, if you can avoid it, to become angry at a patient who's mad at you because you injured them. It just isn't, even if it's a natural response, you've got to try to suppress that instinct. Being defensive is also a natural instinct. Being a little bit cool, being a little too clinical, it's also something that's worth avoiding. It's okay if the patient sees that you're a human being and that you in fact are upset, maybe not as upset as them, but people, you don't want to be too detached. So, what I would like to assert is that disclosure is actually an important part of good quality care. First of all, we need to do it. It's being honest is part of good quality care, but it's also important to helping organizations learn and improve. And it's really very central in many ways to the institution's mission. It's really just part of a good doctor-patient relationship, the ongoing process of communication. And a lot of it's based on common sense. It can be taught so that at least while we should not be scripting things, okay, the next thing I should say is check, there are definitely things that in general people expect. I'm not going to get into this so much, but we've been trying in our organization to do a lot of training and education around this and other things that relate to patient safety. We are training all of our medical students, a lot of our house staff, including we've got a day of patient safety on the first day of internship for our surgical interns, our first year anesthesia residents, and some nurses, so that they can all do it at the same time. Now, I'm going to assert, now that I've convinced you that maybe this is the right thing to do, I'm going to tell you that disclosure is not the solution. I got, my TV went on I had a 10-year-old TV, I got a new one from Circuit City, and it didn't work. I brought it back, and they said, without any complaints, they gave you a new one, and that was great. But no matter how good the return policy, better products are still better. We would like to learn from our errors, improve practice so that there are fewer injuries. And it's good to be able to handle things well, but disclosure and good handling of errors is just part of a more comprehensive system. This is how we've evolved. And it's interesting that we have evolved in the last 10 years away from just disclosure to, we ought to handle adverse events and we ought to think about safety more comprehensively. I've been working with the National Health Service in England, and interestingly, they call all of this being open, or actually they call it being open. And I think this is much better than disclosure. Because disclosure means you're revealing something that you really would like to hide, and being open is just something you should be doing about everything with patients. We need comprehensive systems, and that includes governance from the top, so I'm very happy to see top leaders here. You need to have policies and processes so people know what to expect. The message needs to be consistent, including from, for example, risk management, legal, your malpractice insurer, your other malpractice insurer, and educators. And you need to treat disclosures in a way so that they really feel safe and feel supported. We don't have enough training in general, and we certainly don't have enough support for second victims. We also need to be able to close the loop and learn from these incidents. I will not go into this in general, but this is a diagram of a pretty comprehensive system at the University of Illinois, Chicago, and they try to do everything. A lot of it is run through risk management. This should happen from the top down and bottom up, and we need national policy, but God knows if we'll ever get that. Local policy and local culture, we can influence local structure with training and support. The Brits talk about what happens at the coal face. We talk about at the sharp end. But we need better attitudes that this should be done, knowledge of how to do it, and then we need people to do it. And we actually would like to know, if we dare, how patients are experiencing these discussions. It can all be measured. It does depend on your perspective on what's top and what's bottom. But we can measure all of these things. There are measures that could be and really should be put in place as much as possible. So this is my last slide. It says, I was wondering when you'd notice there's a lot more steps. And, whoops, oh, that's another last slide, but not important, but not to this point. We're here, maybe we're here in our evolution. We can do a lot better. When I came here, I came with high hopes that I would hear about some innovative things that you're doing, and I learned about some of those things, and we're going to do some of those things too. We can all learn to handle these incidents better so that we do better with our patients. We all have patients, we all have people that are important to us. This is my youngest child. And we've got to do things so that fat babies and all of our other patients do as well as they can when they need health care. Our malpractice insurer is very much behind this. I understand yours is as well. The Josie King Foundation actually wound up supporting a lot of our work, which is extremely generous, as Dr. Richardson's family has done. This has become an international movement, and I'm very happy to be contacted in the future. Send me an email, probably the easiest thing. So I'd like to thank you all again for listening so patiently and for having me come down and share a little bit what we've been trying to do. I think we can all learn. Thank you.